down to the eye care experts. We're going to talk in detail. We've talked about this subject in the past. Diabetes Awareness Month is coming up, so we want to dive back into diabetes. Again, joined with Dr. Elkins. Thank you for joining us here for this podcast.
Thank you for having me.
And then Dr. Teresa there. Loving the tie. I hear you. I like it.
Try to dress up for these occasions.
Hey. Well, diabetes, and I'll just kind of start, and we can just kind of go around here. I think day in and day out, I'll probably see more diabetic patients than anything else I see throughout the day. We certainly have, I see a lot of glaucoma patients. I see patients who, a lot of needs, but just day in and day out, there's more patients who are, diabetic that have, mild diabetic changes, major diabetic changes where their vision is fluctuating, maybe their blood sugar is not under control, and these are things that certainly can affect your vision. They can be minor, but they can get major and you can go blind from being diabetic. So these are things that we certainly take serious and we hope that you take serious. So what would you say, I guess, to just diabetic patients in general, or just your experience with dealing with diabetic patients?
Well, we see, especially in our area, we see a ton of diabetic patients. And I think we're just going to see more and more as the years go on. We're all moving to a stationary lifestyle, workspace. The numbers now are way more than it was when I was in school. And I like to tell all my patients, your primary care, your A1C, your blood sugar check and all that has to be done. Make sure you're following up with them. But having a dilated eye exam from a healthcare professional, I think is one of the best things you can do as a patient with diabetes. The first vascular changes you're going to see are in the retina, where the smallest blood vessels are going to be. Some things when you come into us, what we're looking for what we call diabetic retinopathy, which is slight bleeds in the retina from the retinal vasculature, which lets us know, hey, your A1C may be at 8, 8.5, but if we keep seeing bleeds, we're going to have to adjust this and try to, a lot of primary care doctors these days, the goal is under 7, because the blood is toxic to the retina, and we do not want that there if we don't have to. So I stress the importance of, co-managing your care between your primary care and an eye care provider.
Well, just kind of piggybacking on what you said there. I mean, if you're early diabetic retinopathy, most patients do not even know they have a problem. Right. It's like glaucoma patients, certainly to moderate to late stage, you don't even know you have the disease, but by then you can have vision loss, and permanent issues with the eye. So, right. Even if you feel like, hey, my blood sugar's under control, or you feel like, hey, I'm doing all right, you still need to come in at least with an annual once-a-year eye exam. Now, if we're seeing retinopathy like you talked about, if it's mild, maybe mild to moderate, then we usually see those patients, or I see those patients usually 6 to 9 months. Right. And if it gets to be moderate severe, we're certainly seeing you more often because we want to be proactive. We want to try to help you before it gets to a retinal detachment, to get to the point where, hey, I can't see out of my left eye because there's so much fluid or edema. These are things we're certainly trying to prevent. And the only way we can do it is for, as a patient, for you to come in and see us, and that way we can look, like you said, in the back of the eye, the retina, and check out and make sure the blood sugar, the diabetes is not impacting the eye.
Oh, I agree. Diabetes is the second major cause of blindness in the United States. The number one reason being age-related macular degeneration. But to really see this stuff and catch it where it's in the early stages. So any problem, any disease process, the earlier you catch it, the more effective it's like, you name the disease, cancer, heart problems, whatever. The earlier you catch it, the more effective is the treatment and the longer you're going to last because those problems are under control. And we have some of the best equipment out there for measuring vascular changes in the eye. And it's important, but if they never get used or you never come in, then it doesn't do you any good.
And one good thing off what you said is a lot of my patients are like, well, if I do start having bleeds, what does it feel like? I like to tell them, when it comes to the eye, most of your nerve receptors, they're in the front of the eye. You're thinking cornea, anterior part of the eye. In the retina, you're not going to feel a microaneurysm or a bleed in the back of your eye. It's just going to happen. And usually by the time you notice something from diabetic retinopathy, it's usually vitreous hemorrhages or detachments. I tell my patients sometimes, if you're not taking care of your blood sugar, it will cause vision fluctuations throughout the day. It can speed up the progression of cataracts. Sure. That lens will suck in the sorbitol, that extra blood in here, you'll notice small things like that. But as far as pain and bleeds, you're not going to know what's happening until it gets pretty serious.
And those are the patients that I worry the most about, are the ones who are having those big fluctuations, whether it be daily or hourly, where you're having the highs and the lows of that blood sugar going back and forth. And eventually it does usually lead to some retinopathy in the eye. Certainly, like you mentioned, you have a higher chance of cataract development and maybe even a faster rate of the cataract development. But I think one of the good things, and I think it would say for us we've been doing this for quite a while, is when we first started in our career, we used to refer a lot of patients out who had diabetic retinopathy to a retinal specialist. But now, since we all have kind of OCTs, which does a scan of the back of the eye, can look at the edema, but can look at the angio, can look at the fluid of any blood leaking from the vessels at all. We can look at that. We have visual fields. We have B scans. We have so many other medical instruments nowadays that we're able to monitor these patients before we need to refer them to a retinal specialist for surgery. And hopefully they never get to that point. But we know in the past, in the early days, we would refer them, and the retinal specialist would just monitor them themselves because it wasn't to a point where they needed to do stuff. But now we can kind of do that ourselves. Instead of making the patient go through that, it's nice to be able to monitor that internally, and then at a certain point, if it gets bad enough, to say, hey, we need to get you to be seen by a specialist.
Or even on a more basic level, if the diabetes is not going according to plan, and sometimes it does that, then instead of a primary care provider, it behooves us to talk to the patient and consider an endocrinologist or a diabetes specialist to handle those changes in the retina that aren't being addressed. And that occurs too. And we have an obligation to the patient to tell him that. He would have no way of knowing that and thinking he's doing fine. And in fact, he's not. This is not based on symptoms. It's more subtle than that.
Maybe we should get into how diabetes actually affects the eye. So we have what we call in the eye world, we have non-proliferative diabetic retinopathy and then proliferative. The first being is we start getting bleeds in the eye. You get small bleeds all throughout the small blood vessels in the eye. We can get macular edema. The macula is the part of your eye that's responsible for the 20/20 clear vision. But when blood gets there, we start to lose that vision and it starts to go down. And as that non-proliferative gets worse and worse, we start getting more and more blood and more risk factors. And then, hopefully no one, but if it does, you get to what we call proliferative, where you'll get new blood vessel growth in the back of the eye from this toxic blood being back there. And your body, the VEGF, is being released thinking it's trying to supply more blood to the eye. Well, these blood vessels actually cause a ton of problems. They can lead to what we call vitreous hemorrhaging, which is these blood vessels, they're shear and large pools of blood will happen in the eye, and you'll get a sudden decrease in vision almost instantly, and it's pretty serious. And then, some of the worst case scenarios, you're thinking retinal detachments. These are the kind we call tractional retinal detachments, and then they can even grow into the front of the eye, into the drainage system, and cause what we call neovascular glaucoma, all things that could lead to blindness.
So there's a lot of things that certainly can affect you. We talked about the ones who have the big fluctuations. Yeah, it can change your prescription, change your vision. The longer you've had diabetes for, the greater the chances you're going to have some of the issues you mentioned. But a lot of people will say, hey, I was diagnosed 5 months ago. Well, that doesn't mean you've been diabetic for 5 months. You could have been diabetic 5 years before you were diagnosed, a couple months ago. So that doesn't, there are some patients out there that are diabetic for years before they get the official diagnosis.
Right.
So sometimes that's a little misleading, I think, when they say, hey, I was diagnosed a month ago. But, really, how long have you been diabetic for is really what we're looking at.
Well, some people never go to the doctor either. So they just assume they feel good, roll on, and you're good. And that really doesn't apply to these more subtle diseases.
I probably have 3 or 4 a week that I see that never go to the doctor. I see hemorrhages in the back of the eye, send them for blood work, and next thing you know, they're starting diabetic medications to get their A1C down because it's 9, 10.
Well, the good thing that I say about diabetes is most things that are going to happen with diabetes are preventable. Correct. In the sense that if they would have come in to see us, if the patient would have maybe done a little bit better with the blood sugar control, working with the PCP. I know sometimes they start them on new medications. It may take a while to kind of figure out where that target, blood sugar needs to fall, where the A1C needs to be. But if you see us, we're certainly going to try to do everything in our power to get you where it never gets to be proliferative, or never gets to the point where you go blind or you get glaucoma. These are serious things that you won't recover from, or you lose sight completely in that eye.
Right.
And that's a worst case scenario, but we definitely want to try to prevent that. And the patients who don't come in regularly, or are not seen regularly, or those are the ones that we fear the most, where there's damage being done that we can't pick up on or at least help them.
And I feel like the demographics between our areas are pretty similar. What do you think are some of the biggest risk factors you see in patients that have diabetes or that develop diabetes?
Well, we talk about Hispanics and African Americans are at greater risk for being diabetic, but you know, a lot of patients will say, hey, my family history of this or family history of that. So that's definitely relevant. But also, you know, what are you doing? And that's the point you said at the beginning is, are you sitting on your couch all day? Or are you behind the computer just sitting in one spot where we know if you go outside, you know, you get active, you burn. And that's, you know, when we were growing up, thank goodness we didn't have cell phones. And I spent most of my days outside as a kid, you know, running around and playing. And now we've kind of gone to that lifestyle where you're just sitting here looking at your phone. And that is leading to more people who are having diabetes amongst other issues.
And I'll tell you what's promising though is a lot of diabetic patients I'm seeing nowadays are talking to their primary care, doing their annual eye exams, and through diet and exercise, they're actually getting off all medications, getting diagnosed as pre-diabetics or becoming non-diabetic. And so there are a lot of things we can do with not being stationary, taking care of ourselves that can help prevent or even sometimes reverse some of the damage that gets done from diabetes.
And that's a rewarding. That's a good, you know, and that's the goal. The goal is to help you where you never get to be where you have problems, but to get to the point where, hey, maybe you do get off the medications. Right. Maybe it's lose 10 pounds. Maybe it's walk, you know, a couple miles in the evening before you go to bed. Whatever you need to do, you know, get to that point.
I agree. That's the positive side of this. If you can initiate that activity by talking to the patient, and you know, the statistics on people that lose their vision, they become depressed, and at that point they tend to put on weight, which is, of course, is counter to good diabetes management. Right. So it tends to spiral downward.
Well, I know the one thing that I've encountered, and thank goodness we're to this point, is the PCPs, the specialists, the rheumatologists, whoever they're seeing, are realizing that what the eye provider, the optometrist, the ophthalmologist, what we can do by looking in the eye and the way we're able to monitor that disease specifically. And you know, just I'd say last 5 years, but maybe the last 2 or 3 years, we're getting a lot more referrals in from those PCPs and those other outside doctors. And that's a good thing, because we're seeing more patients.
Well, they have insurance incentives that if they get this checked, then they can monitor the diabetes even more accurately. And so that's a good thing.
So if you're certainly you need to be seen once a year regardless for an annual eye exam if you're diabetic. At the baseline, everyone needs to come in for once a year, a dilated eye exam so we can look inside the eye. But if your vision's blurry, if it's black, you're seeing spots, you know, anything that's kind of like, hey, what's this? Or I haven't seen this before. Or, you know, it could be a hemorrhage you're seeing. It could be a lot of things. Come in. I'd much rather you come in and say, hey, this is okay, nothing to worry about, than you not come in and it lead to retinal detachment, a tear or a hole or something like that could have been prevented.
Right. I tell a lot of my patients, if you have a family history of any eye pathology, glaucoma, macular degeneration, but even if you have a family history of diabetes, you need to come in and get your eyes examined every year. You know, at that point, you never know. You know, so a lot of my patients come in and they'll fill out their chief complaint, their history, and I'll see on there that this patient reports that they've been peeing a lot lately, and they've been really thirsty or really hungry, and family history, and then you look at match it all together, you send them in, and now you start their treatment early, and you may prevent some irreversible damage in the future. So, you know, those annual eye exams and your PCP and blood work, it can do great things in helping preserve your vision and your lifestyle and your health.
Well, I think we've all had patients that we've done the exam and we've given the prescription and they've left with glasses and they're seeing great and they're seeing 20/20 and they're happy, and then maybe a week or a month or 2 months go by and then they don't see good at all. And it's not the prescription changed, and it's not the prescription went bad, it's their blood sugar went high or low, and that actually changed the prescription from what it was a month or a month and a half sooner. And so with these patients, not only is it good to get your blood sugar under control because of less chance for complications, but if your blood sugar is not in control, we cannot even get you a pair of glasses with your prescription that you're going to be able to see good out of for any length of time, because it's going to change in weeks or months later.
Right.
That's the whole problem, without getting too aggressive, although I get very aggressive on this point. When you go in or you see advertisements in any media at any time about getting an eye exam and 2, 3, 4 pairs of glasses for $39, that the idea is they're checking you for the glasses, and that's their model, as opposed to getting all the equipment and all the mishmash that's required to check for diabetic changes in the eye. And if you don't have that equipment and you don't do those checks, you're never going to find it. So you have to be careful with doing that, particularly if you have these conditions. Hypertension, diabetes, thyroid condition. I mean, it's kidneys. All these things manifest themselves in the eye. And you have to have someone look at that who's competent and willing to do the work to find out the why of why you can't see, as opposed to fixing it.
Well, that's the reason I think we all agree that, if a patient calls up and say, hey, I've got blurry vision, they assume, and a lot of people assume, hey, it's the glasses prescription. But how do you know it's the glasses unless you look in the eye? If you look at the cornea and see if it's edema, do they have this? Do they have that? Do they have cataracts? Do they have, this related? So we all wouldn't feel right with just, hey, here's a new pair of glasses and send them on their way. We want to get to the root of the problem, why it's blurry, solve that issue, so hopefully this doesn't happen again. Just because I give you a new pair of glasses doesn't mean I solved what the problem was to begin with that got you in that position.
Separating those two things is artificial and done for economic reasons as opposed to logical reasons.
And so that's the reason, uncomfortably, sometimes we want to dilate you every year, and we do ask for all the medications that you're on. The text will go through a full history of yourself, medical history, and along with, family history, because those are things that, hey, they take time, and I know it's uncomfortable sometimes, but we want to figure out, as we're looking, make sure you don't have any of these conditions or you're not predisposed to having these conditions later on. And on the backside, we kind of put all this into perspective and say, hey, this is what we're seeing today. This is what we recommend. This is how often we want to see you back. And so all of that is pertinent to what we do that day. So that's the reason we need all that medical information, what medications you're on, what systemic conditions you've been diagnosed with. Because even some of the things, Graves' disease, thyroid disease you mentioned, even medications nowadays, we have to do testing to make sure it doesn't lead to ocular toxicity.
Right.
You check all that, then you've had an eye exam.
Right.
Not the other way.
Correct. And that takes more time. It takes more time for the techs to gather the information. It takes more time for the patient. It takes more time for us to kind of look through all the scans and the photos and to certainly diagnose, put in the chart, explain to the patient these conditions. But we all view it as worthwhile, and we know that's what's best for the patient, and that's the reason we take the time and do it that way.
And I think all of us up here agree that, yeah, we want to get you seeing great, but I think our number one thing is making sure you as a whole are taken care of and your health is in great shape, not just giving you a pair of glasses. We want to make sure you're taken care of and taken care of for a long time.
Yeah, and then we want you to for a patient for life. We don't want to just see you 1 year and hey, fix that. We want to see you year after year. We want to see your family members. We want to be your eye care provider, both visual and any medical needs you have with the eye. Going through it, we want to thank Dr. Elkins again for joining us. Good lecture. We could talk here for 3 hours probably on diabetes and diabetic retinopathy and things like that. But the main thing is come in to see us. Even if you think things are good, give us a call. We want to look in there and make sure. And then certainly if you're having anything that's worrisome and your blood sugar's off or, same thing, give us a call. We want to see you into our offices. TrezaOptical.com. Thank you.
Thank you, guys.
Thank you very much.